Just as a basic scientist may look at the building blocks of cells and try to understand why some cells may not do as well as others, what I do is I look at the building blocks of healthcare organizations. How is it that some patients go through a healthcare system and do quite well, and in some other cases, another patient might do very poorly. Some of the greatest challenges in healthcare today, I think, are collecting the right information to answer the question we're trying to answer. So we collect about 1,000 variables or more on every single patient that undergoes cardiac surgery across the country. When you look at some outcomes, they vary in their rate widely across hospitals. In some cases, 20-fold variability in how some patients do. Even after accounting for thousands of variables on every single patient, only 2% of that variability is accounted for. We can do better than that by collecting the right things that are impactful and that help explain that variation. My own sense is that a lot of that variation is not attributed to differences in the burden of disease at a hospital, but the way organizations are structured and the way clinicians actually practice within their organizations. While people have the best of intentions, we often work in silos of care and we don't share information necessary to be able to learn from the work that we actually do together. For instance, cardiac surgery accounts for a vast percentage of all blood transfusions in the United States. With blood transfusions, I think a lot of the variability occurs as a function of our own biases and attitudes. We have different perspectives related to the value of a blood transfusion. Those may be grounded in who we are as an individual, whether or not we're a surgeon, whether or not we're a perfusionist, or whether or not we're an anesthesiologist. There's actually an opportunity to intervene on that. If variation were just idiosyncratic, it's hard to actually come up with an intervention for that. But if the issue is that we don't communicate the best we can, we don't share information the best we can come up with a solution for that. One of the things that we've done to try to intervene on unwarranted variability is to come up with protocols. Protocols that say, in this case, the algorithm we ought to use ought to be try this, and then this, and then this. I think if you give people the evidence supporting the recommendations, and they give them a protocol to follow, but allow them to opt out of that protocol in certain situations, I think people are more likely to believe it. That's more likely going to result in a better adherence to that intervention.